All right, in the interest of time, we will go ahead and get started. Thank you, everyone, for joining us today with our Be Well Lunch and Learn titled Breast Cancer Diagnosis to Treatment with Dr. Vasikar. Such a timely presentation with it being Breast Cancer Awareness Month. So we just thank you all for taking the time out of your day to join us. Before I pass this over to Dr. Vasikar, I just want to remind you of two different things. The first being that we do record these, so if you are unable to stay with us for the entire length of the presentation or miss any part of it, you will be receiving a recording of today's session in your email within about a week or so. You can also visit our Be Well website, and we have a list of all the previous Lunch and Learns there as well. Secondly, if you have any questions or comments for Dr. Vasikar throughout, feel free to utilize the chat box or the Q&A. I will be monitoring those and will ask her any questions that pop up throughout today's session. So with that, thank you for being here, and I will pass this over to Dr. Vasikar.
Thank you so much, and thank you for inviting me today to be here and present, as you said, on a very timely topic of breast cancer in this Breast Cancer Awareness Month. And I think when I was asked to present here, I would say I was very challenged because I wasn't sure what all I could put in an hour here. There's so much to share, so much to learn with breast cancer. So I hope this little summary is helpful to you all. So I am Monali Vasikar. I'm Assistant Professor of Medicine in Division of Hematology Oncology with my focus on breast cancer. And we'll talk about the diagnosis to treatment and the journey in between for our patients with breast cancer today. So some of the learning objectives, we'll learn some basic statistics, risk factors. We'll learn of some modes of detection and diagnosis of breast cancer. We'll try to understand different types of breast cancer, which then inform our principles of treatment of breast cancer. So for all of you here, I'd say, think about some numbers. Think about what do you think are new cases of breast cancer a year in US, and how many of them you're thinking, unfortunately, would be fatalities in a year of breast cancer. And if you thought in the realm of about 270,000 new invasive cancers a year, and close to 48,000 in situ, or what we call also stage 0 or the DCIS cancer. Unfortunately, there are still about 40,000 deaths of cancer in women per year from breast cancer. And a lifetime risk of developing cancer is about 1 in 8, and that is about 12.4% of women will be diagnosed with breast cancer at some point during their lifetime. And the risk of dying from that is about 2.7%. Well, that sounds a little gloomier. I think on the other side, when we look at the 5-year outcomes, so for all comers of breast cancer, the 5-year relative survival is about 91%. And of those, if they were early stage 1 breast cancers, that's about close to 99% 5-year survival. That's excellent. But even for regional, it's about 85% survival. And again, these are not necessarily stages, but mostly localized versus regional or distant spread. If you look at men, so about 2,500 men per year may get new breast cancer, with about 480 deaths per year in men. The 5-year survival in men is 84%. Given these lower numbers, most of the screening that we talk about are in relation to women. It would be remiss to not touch upon the racial disparities, however. As one can see in all these different graphs over here, if we start here, I know it's a little too small to see and know the differences. But in women under 40 to 45, breast cancer is commoner in Black than white women. If you see here, that's the incidence. So the overall incidence is higher in white women or non-Hispanic white women as compared to non-Hispanic Black. But if you look at the mortality is unfortunately higher for non-Hispanic Black as compared to non-Hispanic white. In terms of the stage to stage comparison, as you can see here, again, non-Hispanic Black are more likely to present with more advanced diseases as compared to non-Hispanic white women. For Asian, Hispanic, and Native American women, the risk of developing and dying from breast cancer is on an average typically lower. Ashkenazi Jewish women have a higher risk of breast cancer because they do have a higher rate of the BRCA mutation. Again, on a more positive note, as you can see here, the breast cancer statistics have been heading in the right direction. The red line here showing the mortality per 100,000 per year. And as you can see, as we have advanced through the decades, the mortality continues to improve and the number of cancer survivors from breast cancer continue to increase. And this has been possible only because of progress in each of these aspects of breast cancer management. And that is from prevention, diagnosis, treatment, but also more emphasis on quality of life and survivorship. In terms of prevention, we've recognized more and more cancer susceptibility genes. We've come up with better strategies of medication and surgeries to improve to prevent breast cancer. And also perhaps some dietary, environmental strategies that have improved the breast cancer prevention. But most importantly, it has been the diagnostic modalities, the imaging, improvement in pathology, improvement in understanding the biology of breast cancer with biomarkers, and something also called next generation sequencing, where we are going down to the molecular and genetic level of breast cancer. In terms of treatment, we've made great advances in surgery and radiation. We are now moving towards more targeted therapies and precision medicine. And we are also incorporating newer modalities, such as something called immunotherapy in our cancer treatments. Also, we offer better supportive care. Our treatments in terms of long-term follow-up with focus on survivorship and long-term complications.
Dr. Bhaskar, we did have a question come in saying, how concerned should a person be about getting breast cancer if their mother had breast cancer?
And that's a great question. Right here is the answer here. So some of the risk factors for breast cancer, risk factors, the main one is age. It varies with age, and we'll look at a graph coming up in the next slide to know that. If certainly you have known genetic mutation, if you harbor a known genetic mutation, the common one in breast cancer is the BRCA mutation. Your relative risk of getting breast cancer is going to be 200. With the family history, if you have a first-degree relative who was post-menopausal breast cancer, your relative risk of getting breast cancer is going to be higher, 1.8. So for that question, if this is probably applicable to you, but it also depends on what age did your mother have breast cancer at, because if they were premenopausal at that time, the relative risk would be 3.3. Again, if you had 2 first-degree relatives with breast cancer, then the risk is going to go up to 3.6. However, the risk is higher if you've ever had something called atypia. Say you had a mammogram, you had some abnormality, it was biopsied and there was atypia. The risk is going to be 5.3 times than the average risk. And if you had something called a lobular carcinoma in situ, the relative risk is going to be really high, 16.4. A past history of breast cancer past history of radiation for Hodgkin's lymphoma, which in the past included the chest area and the breast area, the relative risk is going to be higher in that instance. In terms of age, go ahead.
Sorry, one other question related to that slide. Could you explain the difference between first degree and second degree relative?
Yeah, a first degree relative would be your mother, sister, your father. However, a second degree would be one removed, could be your grandparents, your cousins, one removed. In terms of age groups, so cancer is a disease of aging. As we age, we incur more risk to get cancer, be that of any type. Older men do get more prostate cancer. Similarly, the older you are, the risk of getting breast cancer goes higher. However, you'll notice that as you get to about 85 plus, well, your risk does go down because perhaps your risk of surviving after age of 85 is also not as much. But you can see here, really, it's after the age of 45 and 50 that your cancer risk goes higher. Some other risk factors for breast cancer could be family history of ovarian cancer. If your first child was born after age of 30 compared to a first child before age of 20, was a slightly higher risk. Late menopause, early menarche, that means starting the periods earlier, or if your periods stop later, or if you had used a hormone replacement therapy for at least 5 years. Those are all, again, slightly increased relative risk of cancer. Some other risks that have been and continue to be identified more and more are a higher BMI of more than 80th percentile and alcohol intake. Similarly, having very dense breast tissue, which on mammogram is how you would know whether they're dense or not, is a relative risk because oftentimes the mammogram may not be adequate to detect any abnormalities in the dense breast tissue.
Question, does breastfeeding an infant have any impact on this?
Yeah, that's a great question. So there is, again, slight benefit with breastfeeding. The idea behind that is once you've reached parity and after breastfeeding, there is something called terminal differentiation of your breast glands. And as a result, breastfeeding can have some protective effect and in fact decrease your chance of breast cancer. However, this is a small protective factor, so that's we're not sure exactly the magnitude of the benefit in the current scenario. One of the main risk factors is also genetic mutations. This is about 10% of women who are diagnosed with breast cancer may have a known inherited genetic mutation. I've just listed a couple common ones here, though there are more and more being recognized pretty much every day, I would say. These are the BRCA1 and BRCA2 mutations, which are both autosomal dominant. That means if one copy of your BRCA1 was abnormal, then you would have what we call the pathogenic mutation, or would have a higher risk for, in this instance, breast cancer. So now that we've learned about the risk factors, how can breast cancer be detected? Many of you may be doing breast self-exams, and there has been, over years, different opinions about self-breast exams, because what they found that this does not necessarily decrease mortality. Oftentimes, depending on the cycle of the menstruation or different situations such as breastfeeding, there may be what we often call lumpy bumpiness in the breast. And these may lead to increased scans, increased rate of biopsies, and oftentimes these could be false positives. These are two different main task force who recommend about screening for cancers. One of them is called the USPSTF, that's the US Task Force Preventive Services. And they actually recommend against doing self-breast exams. Whereas the Canadian task force, they said that, well, there's insufficient evidence. However, on the other hand, American Cancer Society advises that women could start this in their early 20s, knowing that there are limitations and what you always feel may not be cancer, but it's certainly good to know and be aware of your body is what I would typically recommend. And if there is any change, I think it's always a good idea to bring it up with your healthcare provider. That may or may not need further scans or further biopsies or further steps. But I think knowledge is power in my mind, and I would support the ACS recommendation here. And again, ACS says maybe every 3 years for women. So the the other way of detection is clinical breast exam. Clinical breast exam is when you go in for an examination and your healthcare provider is doing breast exams. The USPSTF recommends perhaps there's insufficient evidence. The Canadian task force says it's recommended with mammogram, and the American Cancer Society does recommend it annually for women 40 and over. However, this, again, recommendation may be shifting due to a lot of false positives that may come across with clinical breast exams as well. What we know for certain, though, is the modality of screening, mammography, is definitely what all societies endorse and is recommended. And if there is one advance in cancer that has made the most impact in my mind, is screening mammography. I mean, look at this. Compared to 1980s, we've had 42% decrease in mortality by implementing mammography universally. So when we talk about mammography, we're talking about screening mammography, which is a way to detect breast cancer. And we'll look at some more details about that shortly. Some other ways that breast cancer can be detected is maybe you felt a mass or lump in breast or axilla. Maybe there were some skin changes. Or maybe there are some signs and symptoms from the cancer that has already spread to other parts of your body, such as bone, which at times you may have bone pain. That's a late stage of cancer, and our hope is that with mammography, we are able to capture most of them before. And we know that mammography, you might say, well, this is back in the day with the mammography. How about in current times? And we all know that how with COVID and stay-at-home orders, a lot of these screening tests, a lot of these were closed. And one can see here with all the different scenarios with the pre-COVID stay-at-home order 1 reopening and stay-at-home order 2, the proportion of completed mammograms had gone down. I see myself, those in clinic, where I've seen a lot of advanced stages of cancer coming in because of missing mammograms during COVID. And unfortunately, there was a disproportionate effect of this on the races. We know that for women who were African-American, Latinx, or Asian, they had higher impact of missing mammograms as compared to white women based on this particular study here. So what is this mammogram I'm talking about? In simple words, it's an X-ray of the breast. We do have more sophisticated ways of doing these X-rays, something called 2-dimensional and now even 3-dimensional mammography. It detects about 75% of cancer at least a year before it's palpable. Even for an experienced clinician, it requires the the breast cancer has to be about 2 centimeters before it can be palpable. So we're talking a possible detection of really small areas on the mammogram that can be detected at an early stage and thus can be completely cured. A screening mammography is for someone who does not have symptoms. That means that's something you'll get annually. If you had any symptoms related to your breast, your healthcare provider may order something called a diagnostic mammogram. If someone is worried about the radiation exposure with mammograms, be rest assured, with a mammogram, you get less radiation than background environmental sources a year. And that's less than what you get about, I think it's 3 flights is what is equivalent to a mammogram, though I may be slightly wrong on that number. So when should you start the screening mammography? Now that question gets a little more controversial, again, because different preventative services and task force societies endorse slightly different ages where it would be appropriate to start screening. However, what everyone uniformly agrees is that once you're 50 and above, you do require annual mammography. Between the ages of 40 to 49, some societies, such as something called the NCCN or the American Cancer Society, would recommend to start annual mammography at that time, whereas Canadian Task Force and US Preventative Services, they've said at least recommend against or individualized. So that is where you and your healthcare provider would have a discussion regarding your individual risk factors, and if that makes sense for you to start screening mammography at that time. One other way of detecting breast cancer, one other way of imaging is something called the MRI of the breast. Oftentimes we use MRI for patients who've already been diagnosed with breast cancer, but perhaps maybe for a problem solving, because these are more sensitive than mammograms. Maybe sometimes assessing the exact extent of cancer, the mammograms may hide the exact extent in certain types of breast cancers, like the lobular cancers. It also provides a better idea for surgeons in some cases before they can go and do surgery. For certain high-risk individuals, we talked about how the BRCA mutation puts you at high risk of breast cancer. And for those individuals, perhaps doing an MRI in addition to mammography may be indicated. Sometimes we do it before and after chemotherapy to know exactly how much benefit was there from treatments. For individuals with implants, MRI can be done to look at the actual implants, but also certain individuals with dense breast, and that could be the high risk we talked about, where an MRI would be indicated. So again, different societies have slightly different recommendations, but in general, if you have a known genetic mutation, such as the BRCA mutation, perhaps in that case, your mammography may need to start even sooner, such as age 30, and MRI even earlier at the age 25 to 30. If you had breast cancer history and dense breast, which your cancer was diagnosed at less than age 50, then maybe a mammogram and MRI annually could be indicated. Similarly, with history of chest radiation, could be as soon as age 25. Also high risk, we talked about the atypia and LCIS, or personal cancer history, would be another reason to consider MRI. If for any reason MRI could not be done, there are certain ultrasounds, something called automated breast ultrasound, and that perhaps could be used in lieu of MRIs. And once we have detected this on an imaging, once we've made that radiologic diagnosis of breast cancer, we would want to confirm what exactly it is under the microscope by doing a biopsy. So typically the FNA, or fine needle aspiration, which is a less invasive but often insufficient for a pathologist for analysis, is not something we do very routinely. We could do it perhaps for a cyst or for a lymph node if you've already had a biopsy of the breast lesion. But the gold standard is to perform something called a core biopsy. In our institution, our breast center, which is located on the Hope Drive and is an excellent state-of-the-art facility with fantastic staff there, the radiologist would typically be the one to do a core biopsy, and they do it under the guidance of either the mammogram or ultrasound, or perhaps even MRI, depending on the situation. The core biopsy would actually give an actual core sample of the area of interest, and would then be sufficient for our pathologist to perform additional testing. In uncommon instances, there could be a possibility where there may be recommendation for additional tissue excision. So what we call an excisional biopsy, where a surgeon may have to go in and excise an area to know exactly what that is. Once the pathologist gets this sample, they would then look at it to classify the breast cancer as either a ductal carcinoma, a lobular carcinoma, something called inflammatory carcinoma, or rarely Paget's disease, where there is involvement of the skin, and this could be what the patient's experienced too, something called phyllodes tumor, or rarely angiosarcoma. The invasive ductal carcinoma is the most common type of invasive breast cancer. However, there could be some other pathologies. The common one is what is called not otherwise specified NOS, but there could be tubular mucinous, tubulolobular, metaplastic, and micropapillary. This is basically talking about the ducts and the lobules of the breast. When we talk about ductal carcinoma, this is where we're saying it arises from, whereas this is the lobule that is giving rise to the lobular carcinoma. As you can see here, these are some of the stained slides that the pathologists review. You can see here there is more structure, and this resembles a lot what we have showing here in this cartoon. And this is what we are calling a well-differentiated carcinoma. Whereas in this particular slide here, you can't make out any ducts or lobules. It's pretty all these big cells that look like they are pretty active. And this is what we would call a poorly differentiated or a grade 3 carcinoma. The pathologist would then further stain these slides with special stains, because what we need to know is what is the receptor status, or which in essence gives us a clue of what are the growth pathways, ways of proliferation for these cancer cells. So the 3 receptors of interest to us, the 2 of them are the hormone receptors. The ER stands for estrogen receptor, and the PR stands for progesterone receptor. These are the female hormones. They function as what we call transcription factors that regulate gene expression through interaction with hormone responsive elements, and basically cause the cancer cell to proliferate. The PR is also essentially an representation of an active ER pathway. So we are saying that ER and PR are both the same. These do predict response to endocrine treatment. That means if you're very strongly estrogen positive, the pathologists are able to assign a certain percentage, ranging from 0% to 100%. And if you're strongly estrogen positive, then you're very likely to have response to the estrogen blockade, which we'll look at in a few slides here. The third receptor of interest to us is something called the human epidermal growth factor receptor 2 gene, or also called as the HER2. These are members of the epidermal growth factor receptor, or the EGFR family of tyrosine kinases. These are ways that the cell gets signal for basically, as it mentioned, for increasing its growth. What we are looking for is there an overexpression of this HER2, which is a consequence of gene amplification of the HER2, and which ultimately stimulates cell growth, cell survival, migration, and the angiogenesis for continued sustained growth of the cancer cell. So based on these receptors, we then call the breast cancer subtypes. We call them as HR, or hormone receptor, which could be either estrogen or progesterone. So we call them HR positive or HER2 negative, which is actually the commonest subtype. About 70% of all the cancers are going to be hormone positive and HER2 negative. The other second common is going to be your HER2 positive, and they can be either with hormone positive or with hormone negative. And then the smallest piece of your pie is going to be HR negative and HER2 negative, which is basically your estrogen negative, progesterone negative, and HER2 negative, also called as the triple negative breast cancer, which is going to be the most aggressive form of breast cancer. So now that we know the diagnosis, now that we know the pathology and the subtype, the next thing we're going to do is stage the cancer, assign a stage. I'm sorry, this one doesn't project too well, but staging itself is for breast cancer, is pretty complex. We usually assign what we call a T stage or tumor stage, which is basically the size of the breast cancer itself. Then we assign an N stage or the node stage, and that's based on your imaging, the mammogram, your MRI, maybe biopsies to know if you have positive lymph nodes or not. Then we assign an M stage or a metastatic stage, which means has the cancer spread to other sites other than breast and the axillary lymph nodes. And based on these, we assign them between T1 to T4 based on the size. We assign them from N0 to N3 based on how much lymph node involvement is there. And then we assign them either M0, which are not spread elsewhere, and M1, which means it's spread elsewhere. Anytime there's M1, it is automatically a stage 4 cancer. A stage 3 cancer could be, as you can see here, different involvement, different sizes of the tumors with different combination of the lymph node involvement. And your stage 1 and 2, again, will be a different combination of your smaller size of tumors and less lymph node involved. There's also a stage 0 cancer, which is your carcinoma in situ, which is non-invasive cancer and has not spread outside of the ductal cells yet. As a next step, we often do further scans. However, for patients who do not have any symptoms, between stages 0 to 2, what we call early stage breast cancer, our current guidelines to recommend against using imaging such as PET, CT scans, bone scans, or doing certain what we call tumor markers. As luckily, fortunately for breast cancer, the incidence of metastases without symptoms is extremely low. However, for patients who are stage 3 disease or who have any symptoms suggestive of spread of tumor, we talked about how they could have bone pains of spread to bone. Those are the ones where stagings are recommended. Staging scans such as PET or CT are recommended. I know I've talked a lot about cancer in females and women. And I even touched upon some statistics of breast cancer in men. But I want to make sure that we all recognize that there is importance for us. There is lack of knowledge, including me myself, with some biases of cancer care in sexual and gender minority. We know about 5 to 7% of our population are of sexual and gender minority populations. And we can do much more to ensure that our sexual and gender minority persons feel safe in a clinical environment. Our ASCO, which is the American Cancer Society of Clinical Oncology, which is one of our main cancer societies, has been pretty forward in this thinking and has put out position statements about strategies for reducing cancer health disparities among sexual and gender minority populations. They outline 5 areas that continue to be addressed, such as patient education and support, workforce development and diversity, quality improvement strategies, policy solution, and research strategies. We are just starting to learn about this, and I, again, would accept that my knowledge in this is pretty low, and I would continue to learn. But one of the good resources to learn more about this is from clinical guidelines, advocacy, and legal resources, as mentioned here. It is important to not confuse sexual orientation and gender identity. Lesbian, gay, and bisexual people have a minority sexual orientation, but they do not necessarily have body parts or exogenous hormones that could alter the cancer screening and clinical management recommendations. On the other hand, for persons who have undergone gender affirming surgeries, who identify as transgender, for them, if as a rule, if an individual has a particular body part or organ, which otherwise meets criteria for screening based on risk factors or symptoms, then screening should proceed regardless of the use of exogenous hormones. And this is based on University of California consensus guidelines. So for example, for breast cancer, screening should be performed for trans feminine people with 5 or more years of estrogen therapy who have achieved at least at the age 50. Screening for trans masculine people should be individualized based on degree of breast tissue if breast reduction or bilateral mastectomy has been performed. So I'd urge you to be mindful of these guidelines and resources, and make use of these resources as you continue to care for our sexual and gender minority populations. Now, once we've gone through all this journey and come to this diagnosis, where we now know the receptor status, then our next question would be, okay, how do we treat this breast cancer? Our breast cancer treatment paradigm is currently based, again, on the receptor status. We talked about the ER and PR, the hormone receptors, the HER2 receptors, and the triple negative breast cancer. And that's how we would divide it while we look at our treatment strategies. I want to give you an overview of some of the treatment strategies that we employ. The first one, it's called anti-endocrine therapy. This is a broad term, but often it also is anti-estrogen therapy is what we would refer it to as. We saw that, almost 70% of cancers will be hormone receptor positive, and that's why the anti-endocrine therapy is what we would recommend in those cases. These are typically oral medications, though there can be some injectable. These are typically non-invasive. We know they're very successful in inhibiting progression or recurrence of disease. Oftentimes, we recommend these for at least 5 years. And the 2 broad categories that we use is something called SERM, selective estrogen receptor modulator. And the agent we use for that is something called tamoxifen. The other group is aromatase inhibitors, also called AI. And we'll look at these in a little bit detail shortly. One of the other endocrine option is also ovarian function suppression, where we are talking perhaps for premenopausal women about either removing ovaries surgically or chemically ablating ovaries as a means for reducing estrogen production. When we look at tamoxifen, it's acting here directly on what we call the ER, or the estrogen receptor, inside the cell. And they are directly going to act on your estrogen receptor elements at the level of the signals at the estrogen target genes. And thus, because it's blocking at this receptor, it will block the proliferation of cancer cell. The aromatase inhibitor are something that will block the production of estrogens from your body's natural steroids, such as androgens. So what is this tamoxifen? So tamoxifen, as we just saw, is an estrogen receptor blocker, but it's something called selective estrogen receptor modulator. That means it is acting as a blocker at some instances, but at the same time, it is not acting as a blocker or acting as an agonist at certain tissue levels, such as, for example, the uterine lining. It reversibly blocks estrogen. The agonist effects include decreased blood lipid changes and increase in bone density. It is effective both in pre- and postmenopausal women. One of the earliest studies, also called as the Early Breast Cancer Trial Collaborative Group Study, which had then looked at meta-analysis of adjuvant tamoxifen, showed 39% proportional reduction in breast cancer recurrence at 15 years and 30% proportional reduction in breast cancer mortality. The side effects are, it can cause thromboembolic events or blood clots, a low risk of endometrial cancer or uterine lining cancer, menstrual dysregularities, but also symptoms of postmenopause, such as hot flashes. It can also have interactions with other, the CYP2D6 inhibitors. This is where, this is the enzyme that will be metabolizing the tamoxifen. And as a result, those drugs are typically to be avoided, but at least monitored. Gabapentin may be a known hormonal treatment for hot flashes that could be helpful to mitigate the side effects with tamoxifen. The next group of medications is the aromatase inhibitor. And the three common aromatase inhibitor that are all FDA approved for use are anastrozole, letrozole, and exemestane. They are useful only in postmenopausal women. And again, these are some studies that have we've talked about, that have been looked into, and we know that at least 5 years of aromatase inhibitors or 2 years of tamoxifen followed by 3 years of aromatase inhibitors is associated with a significantly lower risk of recurrence of breast cancer and improved survival in women with breast cancer. In some instances, the treatment may be extended up to 10 years. However, this must be tailored to the individual risk and balanced with the side effects, such as osteoporosis, blood clot, cardiac events, vaginal dryness, and also aromatase inhibitor-induced musculoskeletal symptoms, such as joint aches, what we call arthralgias, which themselves might require some NSAIDs or other treatments to help with the management. When we look at the HER2 positive breast cancer, if you remember, we had talked about how this HER2 is a family of the epidermal growth factor receptor. And this is where all these HER receptors are, which give a signal for proliferation through different pathways to the cancer cell. And the most important treatments for management of this HER2 positive breast cancer are two antibodies that have really changed the face of treatment of HER2 positive breast cancer, called the trastuzumab and pertuzumab. These are basically where the trastuzumab and pertuzumab will go ahead and act on these HER2 receptors and thus inhibit signaling and also use other mechanisms such as getting your body's natural killer cell to go ahead and cause apoptosis of this cancer cell. These infusions or injections are typically very well tolerated. These are not like your chemo side effects of hair loss, nausea, vomiting. However, they may have side effects of fatigue, swelling, infusion reactions, low counts, and mainly cardiomyopathy because of effect on the heart. In addition, the pertuzumab may also cause diarrhea and rash. How about in triple-negative breast cancer? Now, since we don't have any targets in triple-negative, our main ways of managing the triple-negative breast cancer is going through the cell cycle and using something called the cytotoxic chemotherapy, which is your traditional chemotherapy in triple-negative breast cancer. The common ones used in breast cancer are something called paclitaxel or docetaxel, cyclophosphamide, carboplatin, and doxorubicin. Again, these are just showing different levels of cell cycle where these chemotherapies work. Additionally, more recently, immunotherapy has been another way of managing triple-negative breast cancer, which is used in certain instances. Now that we've learned of different types of therapy, when do we employ these treatments? And that's where I want you to just have some concepts of systemic therapy considerations in breast cancer. We talk about adjuvant therapy. That means treatment, you've already had surgery, and then you'll be getting the treatment. The goal is to kill any micrometastatic or cancer cells that I call them floating cancer cells. The primary goal is to reduce chances of future breast cancer relapse and reduce chances of eventual death from breast cancer. There's something called neoadjuvant therapy, which is where you get treatment before surgery. The advantage is that this can actually shrink the tumor or the lymph nodes, and thus you may not require as extensive surgery. And this also is kind of a litmus test of knowing whether that particular treatment was effective in our patient, because we'll get results at the surgery and know if we were able to get a good tumor kill from our treatments. There's also something called the palliative therapy, because the adjuvant and neoadjuvant are employed for early breast cancers, whereas palliative therapy is with the intention of relief of symptoms and prolonging life. And this is for stage 4 cancers, which are treatable but incurable. In terms of the surgical considerations in breast cancer, you would either be talking a mastectomy, where the entire breast is removed. The skin and the nipple may or may not be spared, depends on the individual cases or the spread of cancer, and if that's what is intended to be done or not. Also, another way is something called breast conservation surgery, where the entire breast is not removed, because we know that more is not better in surgery in breast cancer. So this could be either a lumpectomy, where just the lump is removed, a quadratectomy, where one quadrant is removed, or a partial mastectomy, where not the entire area of the breast is removed, or a segmental mastectomy. Again, this depends on the size, location, what type of tumor it is, what subtype, what's the size of the breast, age, and other considerations. In terms of lymph node, again, we've learned that more is not better. So we typically tend to do something called the sentinel lymph node. This is testing and removing only the lymph node that typically is draining that area of the breast cancer. If we don't see it on the mammograms or MRIs, or if we don't feel it, that's when we would call it a clinically negative lymph node, and we can do a sentinel lymph node biopsy. The advantage is it causes less of the swelling of your arm, something called lymphedema, less sensory loss, less shoulder defects. However, in some instances, removing all the lymph nodes in your axilla may be indicated, such as if your end stage, the lymph node stage, was 3 or higher. The disadvantage is that there can be a chance of lymphedema, sensory loss, or shoulder abduction defects. Your healthcare provider may also talk to you about the radiation in breast cancer. It's usually, if you've had a breast conservation surgery, in most instances, radiation is recommended. However, in some cases, even when you've had a mastectomy, certain instances, radiation may be recommended. The radiation can be either a whole breast radiation, or it can also be a partial breast radiation. It could be a few days of radiation or more days of radiation, depending on your stage, again, biology, and many other features of the cancer. It's possible that if you are about age of 70, and if your tumor is hormone positive and very small tumor, that radiation may not necessarily be needed, as it does not add to any improved outcomes. So again, there are a lot of aspects that need to be taken in consideration before these modalities are prescribed or not. So having learned all of this, the question we ask is, well, what can I do to decrease my chance of breast cancer? We've already seen the importance of mammogram and screening. And that goes without saying, to get those mammograms, to talk to your healthcare provider if that is appropriate for you and for how often. Some other risk reduction strategies could be your lifestyle modifications. This particular article here from JAMA talked about considering early childbirth and breastfeeding. Well, I'm not sure about if that privilege is available to everyone, especially working in healthcare. But certainly, if that's a possibility, that could be considered. Perhaps more other attainable lifestyle modifications could be to exercise about 3 to 7 hours a week, maintaining a normal body weight, minimizing the alcohol consumption, avoiding long-term hormone replacements. So typically we're talking more than 5 years after menopause, especially progestins. In terms of diet, we are finding that decreased processed foods, incorporation of whole grains, more plant-based diet, and some data on low-fat diet, though again, there was a not sure how exactly that would translate to how much fat content for us that would be, could be something that could be adopted. We are also learning more about Mediterranean diet, which has been definitely shown to reduce decrease of cardiovascular risk, but also now being studied in breast cancer prevention. All this together could decrease the estimated risk of 30 to 80%. How about supplements? I get that question often. Can I do supplements for preventing cancer? Can I take some turmeric? Can I take zinc? The American Institute of Cancer Research recommends not using supplements for cancer prevention, as not only are they not clearly regulated, so you really don't know what you're getting when you pick up that supplement over the counter, but also because these studies are not robust, and we don't know if they're necessarily helpful to you. On the other hand, some of the supplements, such as antioxidant, could actually work against some of the treatments that you're going through, such as chemotherapy. The antioxidants are actually antithetical to how a chemotherapy would work. Instead, focusing on eating whole foods will help your body absorb a range of vitamins, minerals, and antioxidants that get to work together to protect your health. One other strategy, especially for some with high risk, such as if you've had that LCIS or atypia, if you've had any genetic mutations, or some other ways where your risk is really high, you could discuss with your healthcare provider about using these actual medications, the anti-estrogens, tamoxifen, the anastrozole, to maybe up to 5 years to decrease breast cancer risk. Again, these are not for all and need to have a case-to-case basis discussion. If somebody does harbor the BRCA1 or BRCA2 mutation, perhaps for them, they may consider bilateral mastectomy to reduce their risk of cancer. Tamoxifen may be another strategy for them. For their ovarian cancer risk, they may consider removing both their ovaries, but those would be another surgical strategy to decrease your cancer risk. What if you've been diagnosed with this stage 0 or non-invasive breast cancer? For this stage 0 breast cancer, again, we would go through the imaging, the pathology, and then typically your surgeon would recommend either the lumpectomy or the mastectomy, followed by radiation. And then your medical oncologist would discuss with you if there would be a role for one of these endocrine therapies, such as tamoxifen or aromatase inhibitors. Typically, chemotherapy is not recommended for a stage 0 or DCIS. For early stage breast cancer, which is stage 1 through 3, early 3, again, depending on the receptor status, you may or may not have surgery first, and then you may or may not get chemotherapy, where you would typically get the hormone blockers that we talked about, the tamoxifen or the aromatase inhibitors. Oftentimes, there could be a role for some what we call the genomic testing of the tumor cells, which can give us a score and a better understanding of whether you do need chemotherapy or not in this setting. If it is a HER2 positive early breast cancer, depending on whether it's estrogen positive or not, again, you may get treatment with the trastuzumab, pertuzumab, with or without chemotherapy, with or without endocrine therapy, either before or after surgery, depending on your stage and your specific instance. For triple negative, unless it's a very small tumor, you would typically be getting chemotherapy either before or after surgery. What if you already had somebody had a stage 4 cancer? This is where we talk about the palliative treatments because we don't think these are curable, but they're still treatable cancers. And with recent advances in breast cancer treatment, we have a whole gamut of options, which is not possible to cover in today's session. But rest assured, these are very well tolerated treatments and have been very successful in all different types of cancer subtypes. Lastly, because we have such great outcomes for breast cancer, we know we'll be following up these patients in our clinic in long term. And that's where we'll talk about other aspects, such as continuing the mammograms, continuing to make sure with the lifestyle, with adherence to medication, and continuing to coordinate between your different healthcare providers so that you live a long and healthy life and you be well. So with that, since we are top of the hour, I am going to, this was the last slide of summary anyway, and I'm going to stop sharing here.
Wonderful. Thank you so much, Dr. Vasikar. We did have a number of questions in, but we are at the top of the hour and we don't want to hold anybody up. So we truly appreciate your presentation today. Very informational, had a lot of information, and we hope everyone found it super valuable. Again, PowerPoint and the recording will be sent in a follow-up email, so look for that in about a week or so. So with that, we thank you all for your time. Another big thank you to Dr. Vasikar. Have a great day, everybody.
Thank you very much. And if anyone wanted to email me any questions, if I missed here, please do so. I'd be happy to answer. Thank you.
Wonderful. Thank you.